quick and dirty hamstring assessment. The goal is to take 20 minutes to take 1 minute or less. So we're gonna assess his range passively, knee-based, anything here. Okay, so passively his knee is okay. We'll see how his strength is, pull your heel to your butt. Okay, we'll assess 3 degrees, 90, here, go. Anything there? Relax. From here, 10, go. Anything? Okay, so if they had, relax. If they had pain in any of these angles, 90, 45, or 10, we can start putting that in the back of our head as to what interventions may be helpful or what might be hurtful for the patient. We want to find the pain location. So is it more proximal towards the origin of a hamstring? Is it mid-belly? Is it distal? If it's distal, is it more on the tendon? Is it more on the popliteal fossa? Where exactly is it? And if it's knee-based, hip-based, hip extension-based, adduction-based, these are all things that we want to start putting in the back of our head for this assessment. So knee-based, fine. If we do passive range of motion, hip-based, anything here. Okay, if I have them hold, anything here. Okay, knee bent, or sorry, relax. Knee bent, lift up, anything there. Okay, down, leg straight, long lever, lift up, reset. So a lot of people, especially, he doesn't have anything wrong with his hamstring, but if they did, people would usually have pain with something knee flexion based from one of these positions, and active hip extension would be painful. So from there we can assess his glute firing pattern. So I won't tell him what I'm doing because I don't want him to bias his muscle firing pattern, but lift your leg up again. Reset, lift up, reset. Usually if someone has some type of tissue damage to their hamstring, they'll want to fire their hamstring before their glute, like their glute firing pattern efficiency will decrease. So one of the primary motor firing patterns we'll try to improve is glute before hamstring. So lift up again, reset. Daniel does a good job of doing it, but someone that has a hamstring injury or hasn't had to train this before will have a really difficult time of firing their glute first. So this is just an intervention we could start with that's super basic and might take half the session. They might pick it up in 2 reps. It really depends on the athlete. But go again, reset. We could just use tactile feedback and that's enough for patients, but every patient will take a different amount of time to improve. Go, reset. Usually they'll fire hamstring before glute, and once this becomes better and it's glute before hamstring, we can get contralateral QL involved. So the true pattern is glute, hamstring, contra QL. If there's any change in pattern, whether it's contra QL first or hamstring first, that's something from like a muscle timing thing that we'd want to try to improve. So that's a prone assessment, facing up. Okay, hip flexion based assessment. Drive it, pull the ankle down to my shoulder. Anything here, reset. Anything here, pull, reset. So prone, knee flexion, prone, hip extension, and then supine, hip flexion, pulling into knee flexion. This one's going to be a little bit more specific to sprinting because this is the action they're in when they're here, lifting up and then pulling through. All of these are helpful and can help guide your treatment. If he has more pain in a hip flex position, then we could scan the hip, as you guys might see in the other videos, and then that could help guide the treatment as well. So prone, supine. A lot of people will also have disguised adductor injuries that they think are hamstring injuries. Adductor magnus is a big one. People will be like, oh yeah, I have pain like right there in the back. Okay, so then we want to scan the adductor, pull here, midline. Reset, drop the knee down, lifting up. Short lever from 0 and from a max adducted position, and then long lever, same thing, pulling in, reset, and then here, reset. These are all pieces to consider when assessing a hamstring: prone knee flexion, prone hip extension, supine hip flexion, and supine knee flexion. Abduction as well. Any questions? If the adductor is the main thing that's weak or painful, then treat it as an adductor. If knee flexion, doesn't matter hip base. If knee flexion is painful from hip flexion or extension, treat it more knee based. If it's more hip based flexion, then treat more hip.